with BRCA mutation, if you paid attention to the previous talk, we did talk about BRCA mutation. BRCA mutation is a change in the DNA called BRCA. It's in chromosome 13 and 17, that's 1 and 2. And what happened is they have problem with repair of the DNA. And as such, they seem to have a unique response to DNA damaging agents such as, anybody? Platinums. And now the fancy targeted drug is called PARP inhibitor. Are you with me? That's good. Okay, so what are the clinical characteristics? So unfortunately, I think for you all that have been practicing in oncology, you'll see they affect young women. I did have a young woman in her 40s. She got 11 kids, single mother, triple negative hepatitis disease, poor prognosis, younger woman with high chance of relapsing despite treatment. And they have a unique pattern of recurrence. And as the picture is showing it here, they have a unique early recurrence, the first couple of years, maybe usually to say 2, 3, but up to 5 years, and then it plateaus down. And then it recurs, it's very nasty, it's aggressive, it comes in the organs called viscera. Usually brain, 40%, that's really high, lung, liver, so it's quite a nasty disease. So as such, the outcome, the prognosis or the survival is quite dismal. It's just over a year. We usually say 12 to 18, and I want you to remember that figure. And essentially, the 5-year survival is pretty not great either. It's less than 30%. So, and this is a study retrospective in the US. So when they looked at women who were treated, about 300 of them treated in their center, you can see what I'm trying to show you, that the proportion obviously as different line gets smaller, but the duration of treatment in the middle picture here is shortest. I don't think it projects very well. The lowest one is actually triple negative breast cancer, so the duration is shorter. And it's not uncommon. Whenever we treat breast cancer triple negative, 1, 2 cycle looks promising, third cycle, it gets worse. And that's what happened. Therefore, the survival is pretty bad. So clearly, it's telling us that we need to advance, innovate. Just like Malaysia, we need to innovate. Malaysia boleh. But, so, I'm sorry, it's not meant for us to really know. Even I am not 100% be able to tell you exactly, precisely what it is. I put this up just to say that now with the advances in genetic genomic expression, people are trying to classify the intrinsic molecular changes within triple negative breast cancer. And you can see there are many. And according to this graph, there's 6, and there is some overlapping. And most commonly, triple negative breast cancer, about 70 to 80%, 75% will be basal-like. Basal-like is an old term based on because they found that they have cytokeratin expression. But essentially, there's a bit of overlap. And certain subtypes, for example, the basal-like that is close to the immune-associated IM on the top left actually has a better prognosis. So they already understand that some triple negative breast cancer has a lot of immune effects in the tumor microenvironment around the tumor, so you can manipulate with some interesting innovative drugs. So, okay, so finish part 1. Okay, part 2. So what are the current treatment options in advanced disease for triple negative breast cancer? And I'm sure chemotherapy has been used a long time, and I'm sure all of you are familiar with chemotherapy. And chemotherapy has been the backbone of cancer treatment. As such, treating triple negative breast cancer use a lot of chemotherapy, and there are some challenges. Obviously, you heard before that these patients will have relapse, so what previous treatment matter? And when they have previous treatment, the carryover side effect, residual side effect, something that you should also take into account. And they also can come back with a bang. It's quite aggressive, and you really need good, quick, rapid, good control, because patients' performance status, their fitness can be affected, and because it's a very heterogeneous, macam rojak basically. So you need to kind of tease it out, and with a more modern way of genomic sequencing, such as NGS, we hope that we could tease out the different subtypes, the biology that can direct towards treatment. And of course, you heard about, there is interestingly a link to some familial cancers. And in the past, so it's not just knowing, because we need to know that, not because we want to decide what treatment to use, but we also, it has the implication of the family has got some risk. So that's a field that is growing right now in oncology. Of course, we all, In oncology, kita memang jadi kepo a bit because the social history is important. You need to know, single mom, where do they live, how many children, how are they coming, and everything. So hair loss, so that is a consideration. So there's a lot of factors that you need to take into account when you choose the therapy. So apologize, don't get worried about this. I like to think logically, and I think it's a lovely algorithm. So you just bother yourself with whatever in the square red line. So you can see for triple negative, so hormone receptor negative, HER2 negative, the treatment is chemotherapy. There's no specific chemotherapy drug that you use specifically for triple negative breast cancer, but if you entertain that they have BRCA mutation, you might want to have a DNA damaging agent, and I'll explain a bit more about BRCA later. So poly is in inverted commas, if you notice, and there's also a targeted agent, bevacizumab, in this guideline, so it's approved treatment. Can I continue or what, Azad? Two minutes break is good. Okay, I can presume. So when you look at the actual triple negative breast cancer algorithm, and you can see that genetic counseling comes way up on top. And then there is a controversial with whether you'd use monotherapy or combination chemotherapy. Of course, there are rules. If the patient is very unwell because of a huge burden of disease, you need rapid response. They're going to go what we call visceral crisis. That means their liver is going to fail. They are short of breath. You need something that responds quickly. So you need to use more than one drug. And you might want to consider platinum combination at that point. And the first line is usually some kind of anthracyclines or taxanes. And then after that, you have got a more array of choices, as you see. But I think this discussion usually happens with oncologists. NCCN, which is National Cancer Center Network, is American, and it's actually more up to date. So you've seen all that listed, but the reason I'm putting it in is because since last year, the era of immunotherapy has come in. You've heard that before, and that has finally come into breast cancer after a lot of hard-seeing and non-hopeless outcomes. So I think it's very hard to understand all this, so I hope that I can tell you kind of a story so that it all makes sense. So what are the innovation or newer strategies that can utilize whatever is available right now, cytotoxic, to break through the barriers of limited outcome for triple negative breast cancer? So these are the selection of drugs that I think might be worthwhile for you to know. The first of all, chemotherapy, you heard before, sequential is preferred, because if you use combination, although response is better, does not mean the survival is better. You know that survival is the most powerful and the most important outcome, because there's no, it's yes or no, alive or not. So there are a few classes of chemotherapy you can see here. I prefer taxane actually for triple negative breast cancer, but all these agents are all in the guidelines. And patients generally would, because there's no other alternative therapy, they would remain on this agent for as long as we can. Sometimes people do metronomic chemotherapy, low dose, so that is on and on and on, because you have no other way to control the tumor. So you give the treatment until best response, or this progression, toxicity, or in Malaysia, maybe a lot of patients actually do not want to go on for too long. So taxane, there's a few important classes of drugs. Docetaxel, you know all this? Does it ring a bell? Have you heard this? Yes? Okay, docetaxel, paclitaxel, and the new one is nab-paclitaxel. Nama dia Abraxane is albumin-bound paclitaxel. It's quite expensive. So the schedule matters. For paclitaxel, it's quite 3 hours of infusion, allergic reaction. They have a lot of neuropathy. Pre-med is required. It's quite manageable, tolerable. Nab-paclitaxel is pretty easy. The dosing is 100 to 150 mg per meter squared weekly or 260 mg per meter squared every 3 weeks. You don't need pre-medication. It's in 30 minutes infusion. It's really much easier than the 3 hour. And sometimes docetaxel, they get allergic reaction and you have to re-challenge and that take a long time. So this is a study done long time ago, 2009. So at that time, they wanted to know which agents were going to work best for metastatic breast cancer. And it's a phase 2 trial, and you can see the different schedules as noted. So they wanted to compare with the traditional drug, docetaxel 100 milligram per meter squared, which is controlled for US, Malaysia 100 milligram meter squared, only for the tough, okay, not for everybody. So if you can see in this graph, what I'm trying to tell you is progression for survival, which is how long you can control the tumor from progressing over time. And you can see the best regime is, are you looking? Abraxane, weekly Abraxane. It doesn't project well. And the difference between the control arm is about 5 months. And even at that time, this overall survival with that regime was actually the longest as well. So it's showing the activity in metastatic disease is very good. So what else can be done? TNT trial, triple negative trial, is actually trying to understand about platinum, a DNA damaging agent. Would it work quite well in the setting of triple negative breast cancer or BRCA mutation? Now, BRCA mutation, basically, patients have problems repairing their DNA, which have double strand breaks. Okay, they have a weakness, they have a problem, they're mutated, they don't repair very well. So they are trying to see whether platinum, which is a DNA damaging agent, where does it fit in that sort of patient with triple negative or patient with BRCA mutation. So you can see that for all patients, if you see everybody, BRCA mutation present or not, no difference, and that's what it's trying to show you. But for BRCA mutation, you see the response rate nearly double, and that really translates to progression for survival of doubling. And if you take out all the patients, you take out the non-BRCA group, actually no difference. Actually, there's no difference. And even if you do different sequence, also because they allow crossover, if they fail, also no difference. So that's sort of saying to you that carboplatin DNA damaging agent is got activity for BRCA mutated patient. So how about our friend Abraxane? So if we combine with carboplatin, this is tenacity trial, very important trial. It's used in, this trial is in the setting of triple negative breast cancer. So you already heard it's not very common. It's very hard to get patients to be recruited into TNBC specific trial. So we want to assess whether the combination of Abraxane or nab-paclitaxel and carbo would be better or not. And I'm sorry, it's not great, but you can see the result. They show that it is worthwhile because progression-free survival, I don't remember the figures, is significant, and the response rate also is better. There is no difference in overall survival, but there is a trend towards that. So that again, saying that Abraxane and platinum is really, really good for triple negative breast cancer. And that's the reason why I'm telling you about Abraxane, because development, the development of chemotherapy always used on the best treatment forward, because you have to be fair, like your children in class, you don't want to compare with the least smart people in class, right? You want to compare with the best student in class. Another drug that must be mentioned is eribulin. Are you familiar with eribulin? Halaven? Yes, I think I do again. Eribulin is actually in a non-taxane. It's actually quite an interesting drug. It's a non-taxane, but it's got a few dimensions of its mechanism of action. So it's like taxane, but it's non-taxane. It stops the cytoskeleton, some kind of skeleton inside the cell that involved in chromosomal division when when the cell growing. But it also has got some immunomodulatory and also some effect on the tumor microenvironment. And you can see from the classification just now, there are some triple negative breast cancer microenvironment is of interest because patients who have high tumor infiltrating lymphocyte, a lot of tumors in the vicinity actually can do quite well. So EMBRACE actually is very ambitious. It's not first line, so actually patients are heavily pre-treated, 2 or 5 lines, and they wanted to see whether survival will improve. And it's quite brave, considering none of the trials actually at that point show any survival benefit. So they have a sister drug called 301, and actually similar design, just earlier stage, but in this study, actually there is no significant benefit of the drug. The eribulin is working. However, there were signals. I didn't show you, but the subset analysis on these individual trials showing that it is of benefit. And actually, on request by the European Regulatory Authority, they put in both trials in one, and they see actually it did. So for the overall population, actually it benefit. And in fact, the triple negative breast cancer, if the line moves to the left, they are quite favorable for eribulin. So you can see for triple negative breast cancer seem to benefit more with eribulin. So just 2 slides about anti-angiogenic. Have you heard of Avastin? Oh, okay. Avastin, based on again on the genetic signatures, they have very high level of expression of angiogenetic signals. Therefore, it's been tested before, and you can see that there is benefit, especially in this trial, which used paclitaxel and bevacizumab, in which the PFS is longest at 10.6 months. Okay, so now we are going to talk about the novel treatment 130. Okay, the newest treatment in triple negative breast cancer. So first of all, I'm going to talk about PARP inhibitors. And it's actually incorporated into the American guidelines. As I told you, they are very up to date. The drugs that, I don't know whether you heard of it, olaparib and talazoparib. Yeah? Pernah dengar ke? Wow, okay, good. So I need to tell you background. I promise you what I'm going to tell you a bit about BRCA. So BRCA mutation carriers, about 80% of them will become triple negative breast cancer. And when they have BRCA mutation, what happens is they cannot fix if the cancer is obviously uncontrolled growth, right? When you grow very, very fast, you will make errors, and you have sometimes DNA breaks. But when you have BRCA mutation, you don't fix it very well. So when you what happens is if you add another pathway to block using this agent called PARP inhibitors, such as olaparib and talazoparib, blah blah blah. So you block A and you block B, so they have no chance. The cell become unstable and they die, and that's what synthetic lethality mean. Okay, so you just block everything. So Olympiad is a study, very important study for us, because it actually obviously. Olaparib is not a chemotherapy, it's a pill. It's a targeted pill and monotherapy, and it's compared to, this is like real world. So patients were using monotherapy, using the usual capecitabine, vinorelbine, eribulin. And you compare those patients and look for the outcome, which is progression-free survival. Well, and then another company came in, of course. They raised, as usual, drug development is a big area. So BRCA used talazoparib, is by Pfizer, and they have similar trial. However, they are using patients, quite a proportion of their patients actually never been treated before, so they're quite sensitive. But they both must have a germline BRCA1 or 2 mutation. And so what are the results? So actually, it did show that the progression-free survival, the control rates were very good. The risk reduction is 0.5, which is amazing, and it's quite similar for those 2 drugs. And again, when you look at the subset of patients with triple negative breast cancer, they seem to do much better. And then the same. There is no overall survival benefit, but you can understand these are not first line, so it's very overall survival is actually a very high endpoint. A lot of drugs need that to show that, so that they can go to FDA to get approval and so on. So you can see that there is no statistical significance of survival with PARP inhibitors. However, the response rate of these drugs, you can actually, if you look at this, you can see that the drugs work very quickly. Time to go, is it? What, is it better? Atas bawah. So you can see that these drugs work very fast. So patients with triple negative breast cancer, they are, have a lot of bulky disease. They need quick response, and it's oral. There's no hair loss, etc. So it's something that is definitely worthwhile. But you need to select your patient who has BRCA mutation. It's not working. Tak jalan. How do we stick to that? Is it going? Okay, so BRCA mutation. So this is a new field, guys. If you follow, if you all look at National NCCN guidelines, which is comprehensive, it's quite new. It's very good to get new information. They have a whole page. It's really, your eyes will like double cross because it's just so much. So I broke it down here. So patient factors and family factors. And then if you follow NCCN guidelines, inshallah, you will pick up a lot of patients who had BRCA mutation. It's not common. I think Malaysia, as far as I hear from we have BRCA investigators in Malaysia is about 10%, and that's what it is even worldwide. But so essentially for triple negative breast cancer, any patients who are young, less than 60 years old, you should talk about BRCA testing, which is actually germline that we are looking for. And you can see family history. If there's 2 or more first degree relatives, those are the indication. But you have to pay for the test. It's quite expensive, about 3,000 ringgit. BRCA story is always very interesting. I promise you I'll tell you a story. BRCA 1 and 2 was discovered by Mary Claire King. Tahu tak siapa dia? She's a geneticist, and she's the one who discovered, like we and chimpanzee are 99% similar. Okay, so she discovered BRCA 1 and 2, and she also used genetic testing to track patients who were abused. So she is a great woman. Her story about BRCA testing is actually in a movie, Encoding Annie Parker. Anybody of you who like to understand more, make your life a bit interesting, can watch that movie. So the last star of the show is immunotherapy. So finally in 2019, we have entered the immunotherapy era for breast cancer. And I mean, there's so many tumor sites, at least 35 tumor sites where immunotherapy is used. Breast cancer actually finally entered immunotherapy era last year. So it's actually incorporated into the guidelines. And please note that for triple negative breast cancer, PD-L1, so just very specific subgroup of patients. Okay, so cancer immunity cycle, I will tell you my story rather than this story. So cancer cell is actually foreign, so they will release what we call neoantigen. New, it's not part of our body. So sometimes when you get chemo, you break the tumor cell, so it breaks up, it sends out the antigen, and our generals, the antigen presenting cell or dendritic cell, this one, look like a flower apparently. So it will actually take the antigen, the new antigen for cancer cell, and present it to our commandos. Malaysia ada commando kan? So we have to go to the hub where the commando goes, which is in lymph node. So you go there, you tell the commando, you activate them, you tell them, hello, this is new antigen, you need to go somewhere. And then you will send it to, you deploy, you traffic them. So a lot of signaling and so on. And it will traffic, it will send it, and then the tumor cell had to actually go to the point of battlefield, which is the tumor, right? So some tumors are cold and hot. There's a lot of drugs being developed in that regard. So once you go into the tumor cells, so they already have the signal. They're very activated by the boss. Is that right? So they are cytotoxic T cell, the CD8 cells. So that's why in trial we see they look at CD8 cells. And they also look at PD1, PDL1. Those are sort of like the mechanism how the tumor is like stopping all this commando from eating the T cells. And our cytotoxic or commando are very clever. Malaysia commando, one of the best in the world, by the way. And it will kill specific and very successful cell kill. But tumor obviously have a lot of mechanism how evade that. And they also have memory, so that's why it's durable. Patient with immunotherapy can have very prolonged, and hopefully that means survival for patients. So that's quite an amazing story, I think. So I Am Passion 130 is actually a very important trial. It's actually the first trial that has brought immunotherapy into breast cancer. It's actually a global phase 3 study for first line, basically. So they have designed it to be pure, so they have to be first line, they have to be triple negative. So they recruited all the triple negative breast cancer, and they stratified previous treatment, the taxane, and they also look at stratification of the PD-L1 expression. Remember I told you this is a very specific population. The design is pretty complicated. They have two co-primary endpoints. So meaning that first, if you want to see the progression-free survival over survival, you need to measure it on the whole group intention to treat. Only if your your mathematics, your statistic is good, you can go on to check an over survival. So that's how they plan it. It's how they design it. And the chemotherapy that they use is our friend Abraxane, nab-paclitaxel. The dose is changed to 100 mg per meter squared. And Abraxane is at a different dose, 840 milligrams every 2 weeks. And compared to single agent Abraxane and placebo, obviously. And you already know, so in the progression for survival, controlling the tumor, they found that patient over the whole group benefit, but it's actually been driven by the PD-L1 positive IC immune cells group. And as such, it got accelerated approval by the FDA, the drug authority in the US, in last year, March. However, the overall survival of the whole group did not meet a statistical endpoint. As such, for the PD-L1 positive group, they cannot calculate the statistics. However, if you look at the numerical, the value, the delta, the difference is quite significant, 9 months. And remember, I told you to remember a figure earlier? So it's actually 25 months. So remember I told you metastatic breast cancer, triple negative will just live over a year, 12 to 18 months. It's actually broken the 2-year barrier, and that's innovation. So when they look at different groups, I will break it down for you. So you can see the PD-L1 positive, the ones that got atezo will be on the top group. The one that doesn't got atezo will be the bottom group. So it matters whether you atezo or not. The two groups, which is the middle group, which is literally on top of one or the other, are the PD-L negative group. So I think it looked like it's positive. So what is PD-L1 assay that is used? Is very specific, it's very strange. For all other cancers, lung cancer, for example, we check it on tumor cells. But the PD-L1 is a protein which evade immune system from eating it up. So it's actually measured on immune cells. So it's very specific. It's not other cancers that are doing that. And this is what it looked like. So when we are requesting for triple negative breast cancer, whether we want to treat immunotherapy or not in first line setting, I need to tell the lab SP142 and it can be checked in Pantai as SGMC. But you have to pay for it. Okay, so we're nearly the end, girls and gentlemen. So this is the latest 2019, and you can see that for metastatic, it's quite complicated. It's very hard to actually understand NCCN, and you kind of need to have an algorithm because it's literally a list. You can see that PARP inhibitors, genetic counseling, immunotherapy, PD-L1 testing, and so on and so forth is actually part of the guidelines. And you'll be glad. My final slide, because I promised you eat by 2, and that's Mayang. Current standard treatment is still chemotherapy, but then if you can subset them to BRCA mutation or they have PD-L1 positive, you have other options such as PARP inhibitors or immune checkpoint inhibitors. And immune therapy at the moment, one is approved, you have to combine it with chemotherapy, nab-paclitaxel. However, there are a lot of trials underway. Cancer therapy space is a rapidly evolving space. Honestly, I think it's the most rapid ever. So there have been a lot of trials now combining with the cheaper chemotherapy such as paclitaxel. And there's many immunotherapy combining all sorts of things with PARP inhibitors and so on. So because of taking into account the diversity of triple negative breast cancer, so we can see that immunotherapy has making a breakthrough in breast cancer, finally breaking the 2-year mark, and there's lots of research, so watch this space. And with that statement, I'm done. Thank you for your attention.
Thank you, Dr. Azura. Doctor, please remain on the stage. Sorry, just a quick announcement. I was informed that representative from Roche Company is attending our conference today. Is Madam Koh Wan Ling is here? Madam Koh Wan Ling? Okay. I would like to invite Madam Ho Siu Chan to present a token of appreciation to Dr. Azura. Let's give an applause. Yes, we're going to have lunch after this. Thank you, Dr. Azura and Madam Ho. Now, I would like to invite all guests for lunch break. Quick reminder for our participants, please follow your number 1 until 245. You may go to level 4 for your refreshments, while number 2